My name is Evangelos Giamarellos, and I will talk this afternoon about the impact of driving and selecting the prescription, the start and the stop of therapy of antibiotics by using biomarkers. Much of my presentation will come from a clinical trial that has recently been conducted, and published by the University of Athens, where I work as professor of internal medicine and infectious disease. This is my conflict of interest disclosure for this presentation, and allow me to go back to when everything started. After a first pivotal trial that was published in the Flu Journal in 2007, there was a large randomized clinical trial by the group of Michel Wolf and Jean Chastre in France. The idea was that patients with lung infection who were admitted in the ICU, they got a decision for start of antibiotics that was based on the concentration of PCT. As you can see, when procalcitonin was below 0.5 nanogram per ml, as a rule, antibiotic prescription was discouraged. For patients more than 0.5 nanogram per ml of procalcitonin, prescription of antibiotics was encouraged, and when in doubt, measurements of procalcitonin were repeated after 6 to 12 hours. The patient was monitored, and procalcitonin was used by another algorithm in order to decide when to stop antibiotics. So when procalcitonin was below 0.5, or when there was a decrease more than 20% from the baseline, the stop of antibiotics was encouraged. However, when procalcitonin remained above 0.5 nanogram per ml, or the change was less than 20% decrease from the baseline, the decision was to continue antibiotics. And when there was an increase from the baseline, then there was an encouragement to change the antibiotics. The end result is well known to everybody, and it's evident. There is a decrease of the consumption of antibiotic in this parallel trial. After the parallel trial, many other trials appeared, having more or less the same design. But the seminal of these trials is the sub-study. The sub-study included all patients with severe infection. And the idea was to study only the clinical efficacy of a PCT stopping route. The study was multi-center. It took place in the Netherlands. It included all types of severe infection. And from the start of antibiotics, procalcitonin measurements were done daily or until 3 days from stop of antibiotics. The stopping rule was a decrease of procalcitonin more than 80% from the baseline, or any procalcitonin less than 0.5 nanogram per ml. It is the largest trial ever done so far, with more than 1.5 thousand patients being randomized into standard of care and stop of antibiotics based on procalcitonin. As expected, the duration of treatment with antibiotics under procalcitonin was decreased. But among the secondary endpoints of this trial, there was something that was really surprising. 28-day mortality and 1-year mortality were decreased. And all of a sudden, the question was, how is this possible? And not only that, but as it was expected, by using procalcitonin guidance, the cost of antimicrobial treatment per patient went significantly down. And of course, the question comes, what is the mechanism behind the protection from death? And of course, another question is whether just using procalcitonin to stop antimicrobial treatment is enough, or whether we want to understand if using procalcitonin gives another benefit, and more probably important for our patient. This is a meta-analysis of 11 studies that was published at Critical Care in 2018. More than 4.4 thousand patients were included in this meta-analysis. However, it needs to be emphasized that the majority of these patients are coming from the SAPS trial. The use of stopping antibiotics through PCT is accompanied by a significant reduction of 30-day mortality and of the median duration of antibiotics. However, we need to provide answers to the big questions. What is the mechanism of benefit in terms of mortality? And also, is the use of PCT important in another major issue, which is the adverse events that are associated with the prolonged use of antibiotics? We decided to use that in a real hardcore environment, a hardcore environment of our country, where there is a high level of resistance. And these are the data coming from our trial that has recently been published in the Blue Journal. So we enroll patients with sepsis and patients who have sepsis by sepsis redefinition due to lung infection and due to pyelonephritis. We randomized patients into arms. Those where stop of antimicrobials was decided at the discretion of the physician, and those where stop of antimicrobials was decided on day 5, when procalcitonin was found to be below 0.5 nanogram per ml, or when there was a more than 80% decrease of baseline. If nothing of these two applied on day 5, measurements were repeated for 3 consecutive days. And on the day when each of these 2 criteria applied, antimicrobials were stopped. Patients were on an intense follow-up until day 28, and then we continued following them up for 6 months until day 180 in order to meet the primary endpoint, which I will show you soon. At baseline, day 7, day 28, and day 180, we collected stool samples from our. These are the baseline demographics of our patients. As you may see, no difference in terms of age, gender, comorbidities, severity by SOFA score, and empirical treatment according to the guidelines of the European Society of Clinical Microbiology and Infectious Diseases. This is the flow chart. In the end, 133 patients allocated to standard of care, 131 in the intention to treat analysis, 133 allocated to procalcitonin guidance, 125 in the intention to treat analysis. The primary endpoint was not anymore reduction of the duration of antibiotic treatment. We considered that that would happen. It has happened so many times and for so many trials. The question is, what is the benefit behind the use of PCT to early stop antibiotics? So the primary endpoint was the rate of infection-associated adverse events at 6 months, which was a composite by any of infection by Clostridium difficile and multidrug-resistant microorganism, or death by any of these 2. This is the primary endpoint, which is successful. Procalcitonin guidance decreases substantially from 15.8% to 7.5% the rate of infection-associated adverse events. And the question is, can this primary endpoint depend from fecal colonization? As I mentioned, we isolated and we collected stools in order to isolate Clostridium difficile and multidrug-resistant microorganisms on baseline, day 7, day 28, and day 180. And the question was, is the odds ratio to develop this primary endpoint in the standard of care group when the patients are colonized by Clostridium difficile or MDRO on day 7? Yes, it is significant, as you can see in the standard of care group of day 7. But it is not any more statistical significance in the PCT group, and the odds ratio between the two groups differs substantially on day 7, and the same applies on day 28, showing that the benefit coming from the introduction of procalcitonin as a tool to stop antibiotics is associated with a decrease of the colonization of gut flora by multi-drug resistant bacteria and by Clostridium difficile. Our top secondary endpoint was mortality. And as you see, after 28 days, the difference is spectacular. 28.2% mortality in the standard of care group, just 15.2% in the PCT guidance group. And all of a sudden, the question comes, how can PCT guidance affect survival? In our patients, the duration of antibiotic exposure is significantly decreased. And this decrease leads to decrease of adverse events that are associated with the use of antibiotics, cumulatively, but also for each of the 3 main categories of adverse events, which were antibiotic-associated diarrhea, antibiotic-associated acute kidney injury, and all other non-serious adverse events, comprising electrolyte derangements, elevated liver function tests, and arrhythmias. As it is expected, antibiotic consumption may affect hospital stay. As you may see, patients who were allocated in the PCT guidance group were discharged far earlier from hospital compared to patients where the decision to stop antibiotics was done by the attending physician according to their norm of care. This led to substantial financial benefit, decrease of the total cost, decrease of the cost of antibiotics, and of all drugs. So allow me to conclude the base benefits coming from PCT guidance. Regarding the primary endpoint, there is a decrease of infection-associated adverse events, and this is associated with a decrease of stool colonization by MDRO and Clostridium difficile. And this is also associated with decreased mortality, decreased adverse event, which explains this decrease of mortality, and the decreased length of hospital stay is associated with less cost of hospitalization. Thank you very much for your attention.